Welcome back to Orthopedic Tutor. Today we are going to discuss the final part of the Oncology Basics, Part 3, which includes basic treatment principles for musculoskeletal tumor. Now moving on to the treatment, one of the most basic questions that comes when to a resident's mind, especially when dealing with tumors, is how do you treat it? How do you face these kinds of conditions? And when treating a tumor, there's always in mind two different types of treatment method, which is non-operative and operative. The non-operative modalities for this condition includes using common drugs such as bisphosphonates or adding any additional modalities such as chemo or radiotherapy. We all know about chemo, but the chemo itself can be divided further into an adjuvant or neoadjuvant types of chemotherapy. When the chemotherapy drugs are given before any surgery, it is called a neoadjuvant chemotherapy. And when it is given after the surgery, it is called an adjuvant chemotherapy. The regimens used in adjuvant chemotherapy can be different from the ones used in the neoadjuvant chemotherapy. It is all evaluated after the surgery. Lesions are evaluated for their degrees of survivability. If after being given the neoadjuvant chemo, the tumor cells still survive, then the drug regimens must be re-evaluated. Next is the common drugs that are used in musculoskeletal cases, such as the bisphosphonates. There are actually multiple effects of bisphosphonates on the osteoclast. These are summarized from different journals. It is mentioned that it could prevent osteoclast development from its precursors. It could inhibit development of the osteoclast itself. It could reduce the activity from the osteoclast or induce apoptosis of the cells. It could also stimulate the production of an inhibitory factor for the osteoclast. While based on these different mechanisms of actions, the drugs itself can be subclassified based on the presence of any nitrogen side group into the nitrogen containing bisphosphonates, the non-nitrogen containing bisphosphonates. The non-nitrogen containing bisphosphonates are usually weaker, but the nitrogen ones have a more potent in its anti-resorptive effect. The drugs example in this category would be the zoledronic acid or the alendronate that is commonly used in the market nowadays. They work by inhibiting the protein prenylation within the mevalonate pathway, which leads to the loss of the GTP formation needed for ruffled border formation. As we all know that the ruffled border is formed when the osteoclast is sealed on a surface of the bone that is being resorbed. And then the non-nitrogen containing bisphosphonates. It is metabolized into non-functional ATP analog and is usually associated with osteonecrosis of the jaw. And moving on, after gaining a little bit knowledge regarding the common drugs that are used, we shall move on to the next principles that are frequently asked in exams and frequently debated, which is whether or not you're going to perform a limb salvage or limb ablation. Limb ablation is just a simple word for cutting off a limb, and it is usually, when thinking about it, it's usually a go-to strategy for those types of doctors who do not want to conserve any part of the limb that may have the potential of harboring malignant cells. But nowadays, people move towards limb salvage. While performing limb salvage may seem to be nice, it has certain criteria of patient that is required. The criteria include that the local control of the lesion must be at least equal to an amputation surgery. So when you cut off a lesion over at a distal femur while performing a limb salvage surgery, the surgeon must be sure enough that the clearance level of the lesion should be as equal as performing an amputation at the level of transfemoral perhaps, or even a hip disarticulation. The next would be the limb that has been saved must be functional. When the limb that has been resected does not provide any adequate remnants for it to function properly, then limb salvage cannot be done. Remembering these two criteria, one can actually easily determine whether or not the patient is eligible for limb salvage or not. Now, the tumor biology that is involved when considering a limb salvage: when a tumor is growing within a bone, there are certain regions of the lesion that can be found, which include a reactive zone, a satellite lesion, or a skip lesion. Now, the reactive zone is actually a zone that forms around the bone sarcoma itself, and it consists of compressed tumor cells and also a fibrovascular zone of reactive tissue, and it has variable inflammatory component that interacts with its surrounding normal tissue. When the capsule is found in a benign tumor, then it is usually compressed of normal cells. But in bone sarcoma, the capsule is also known as pseudocapsule, and it is composed of some tumor cells. Moving on, satellite lesions are actually tumor cells that are situated around the reactive zone, and skip lesions are lesion or metastasis of the tumor cells that is located still within the same anatomical compartment in which the lesion is located. Such as depicted here, the lesion is over at the distal femur, but the skip lesion is over at the proximal femur region. And moving on, we must also remember the rules of limb salvage, which includes that the criteria should be equal. One of the criteria is that the lesion control should be equal to amputation, and that is one of the reasons why, if there are multiple skip lesions of the same bone that is involved, limb salvage is no longer an alternative. For the limb salvage itself, one of the main goals is that the reconstructed limb must be stable and durable with adequate soft tissue coverage. Now, the surgical margins that is explained by the Musculoskeletal Tumor Society system, they have mainly categorized it into 4 different types, which is the intralesional, the marginal, the wide, and the radical type of resection. As you can see here, this is the picture. When you perform an intralesional lesion, usually a level of tumor cells may still be left behind. And for wide excision, for the marginal excision, usually only a little bit of tumor cells are left behind. For the wide excision, a normal cuff of soft tissue is being taken along with the tumor. And for the radical excision, the whole compartment where the tumor is situated is taken out. And these also apply for bone sarcoma. For marginal excision, then the tumor is taken out at its border with the normal tissue. For the wide excision, a cuff of healthy bone is taken out. And for the radical excision, the whole bone is taken out. Now moving on, for the intralesional type of resection, it has a recurrence rate of 100% in malignant mesenchymal tumor, mainly because the tumor is taken out with leaving a cuff of abnormal tissue still attached to the body. And the intralesional type of surgery include those that is being done through curettage or debulking surgery. For the marginal type of surgery or resection, the surgery is done through the reactive zone. Do you still remember the reactive zone that I've explained earlier? Scroll back if you don't. The reactive zone may be the capsule or the pseudocapsule of the tumor, and it contains inflammatory cells, fibrous tissue, and some satellites of tumor cells. These reactive zone resection may lead to a recurrence rate of around 25 to 50% in malignant mesenchymal tumor. And marginal resection is usually reserved if the response to pre-op chemo is excellent, with 95 to 100% of tumor necrosis. For wide resection, usually a cuff of normal tissue is included, and local recurrence rate drops significantly below 10%, with skip lesions may be left over. And the radical, as I've mentioned, it includes the whole compartment. And after you have considered the types of limb salvage or limb ablation surgery that you would like to perform, then we move on to discussing about the types of resections. As you know that tumor is very variative. There could be a huge pattern of involvement, and each type of involvement should be discussed with a team that comprises various orthopedic surgeons, ones who are skilled in oncology department, and some are skilled in soft tissue reconstruction, and a pathologist should also be inside the group to discuss the prognosis of the conditions and the types of drugs that would usually work on the patient. For the upper limb resections, it is further divided into a primary sarcoma type of resection or a metastatic type of lesion. For the metastatic type of lesion, usually each bone has each types of surgery, but in here I will only present a slight overview, such as those metastatic lesions found in the humerus, which could be further subdivided into proximal humerus, that is further reconstructive endoprosthesis, those in the humeral diaphysis that could be reconstructed with an IM nail, with or without plate reinforcement, and those with this distal humerus involvement, which could be reconstructed with tumor curettage and reconstruction with cemented hardware. These are the picture depicting the locations of the metastatic lesions. Next would be the resection or the salvage surgeries of the primary sarcoma around the shoulder girdle. So in a shoulder girdle resection and endoprosthesis reconstruction, a commonly used classification system comes from Malawi, where there are 6 types based on the site of the lesion and also the type of the excision that is going to be done. And we could see here that there are also 2 subsystems for these, which include those that retain the abductors or those that resect the abductors. It is advised that if you are in this particular field of orthopedic surgery or the oncology department, you should read more regarding these types of incision that is performed, the level of the incision, the markings, the patient positioning, and so forth. Here is only a quick preview of the positioning of the patient. This patient is going to undergo a resection of a biopsy site, and the planned incision is carried out, and the extension of the skin flaps is also marked on the skin. And next would be the contraindications. As we all know that contraindications are always there to remind us that certain surgeries are not to be done, and one of the absolute contraindication that includes in tumor resection is its involvement in neurovascular bundle that I have explained earlier in a previous video, the part 1 video of Oncology Basics, where MRI is usually used to determine whether or not a neurovascular bundle has been involved. And it is the general rule that when there is a neurovascular structure displacement out of its normal anatomical place, some are unresectable. But if the neurovascular structure invasion or encasement has occurred, then the tumor is definitely not resectable. So you must always determine its involvement. And to determine its resectability, you could use this triad, which includes first and foremost pain, second would be motor deficit, and the third would be venogram that shows obliteration of the axillary vein. As you could see here, this is where the axillary vein should be, but here it is no longer visualized because it has been occluded by the tumor. And since the tumor has grown so big, the tumor is actually compressing the vein, which has a thinner wall and thus forth more compressible. And since the nerve is also displaced, the patient may present with pain and motor deficit. And then moving on to the next topic would be the resections of lower limb. The resections of lower limb are fairly straightforward. During the understanding of this topic, it took me quite a while to understand it because anatomically pelvic is very challenging. Lots of structures is going on through, and there are lots of anatomical sites that needs to be known, and you need to have a 3D mapping of its anatomy in order to understand its resections. But basically it could be divided into three types. The first would be the iliac resection, as seen here that the iliac is being taken out due to a tumor developing there. And you could also perform a periacetabular resection with patient placed in a lateral decubitus position. You can see here the osteotomy line of the ilium, the superior pubic ramus, and also the infraacetabular osteotomy. And the third would be resection around the pelvic floor, with the patient usually positioned supine with hip flexed and abducted to be able to reach those particular site, as seen here, one that has grown onto the inferior pubic ramus. Well, going back, you need to remember that all these surgeries are only done when the patient is categorized as patients who are eligible for limb salvage surgery, which must have these two criteria, including the local control of lesion must be equal to amputation, or that the limb that has been saved must be functional. If these two criteria are not met, then patients should undergo limb ablation. And for limb ablation, there are various amputation surgery for the upper and the lower limb. For the upper limb itself, two of the major types that could be done is the 4/4 amputation, and those performed around the elbow, which is the above and below elbow amputations. The 4/4 surgery is rather straightforward because the whole upper limb is taken out. Patients are usually positioned in a full lateral position, and the incision is carried out 2 cm lateral to the sternoclavicular joint, extending to near the deltopectoral groove. The superior border of the incision is the acromion, and during this dissection, the whole upper limb is being dissected. The pectoral muscle is detached from the clavicle with clavicular osteotomy at the proximal 1/3 junction or the anterior, and the major ligaments, the major vessels are dissected and ligated, which is the subclavian, and the whole scapula is detached from its muscle attachment from the posterior aspect, as seen here that the surgeon's hand has gone through under the scapula and dissecting the whole scapula off of its posterior attachment. Next would be the above and below elbow amputation. Usually the flaps form can be standard anterior posterior fish mouth flaps, but in oncologic surgery, the type of flaps that are being done are usually more flexible because even medial and lateral flaps can be done. For the dissections, it is done with myodesis, which for those who doesn't understand these terms, there are two types of muscle reconstruction that is being done. The muscles at the opposing side could be sutured to each other, or it could be fixated to the bone. When it is fixated into the bone, it is called myodesis. And postoperatively, you should always remember that rigid dressing is usually placed on any amputation stump, because rigid dressing not only increase the pain and edema, it also accelerates the formation of a well-healed stump, and therefore will promote the early application of any orthosis. Next would be the resection of the lower limb. Now, there are various surgery that could be done in the lower limb, such as the hemipelvectomy, the hip disarticulation, the above knee amputation, below knee amputation, and foot and ankle amputations. And you could see here that there are various techniques that can be done, especially for the hemipelvectomy, including the standard, modified, or extended. Remember that one day if you are practicing and you are the surgeon, the only surgeon that is available on that area, and you are to perform a hemipelvectomy on a patient, always make sure that you have a very clear image of the anatomy of your surgical field before entering your patient's body, because the anatomy could be so distorted, the muscles could be so distorted, and sometimes you cannot identify what structure is what. Then that is why I would advise that if you are undergoing a hemipelvectomy, you are performing a hemipelvectomy, be sure to have an anatomical guidance around you, have it printed, have it there, the book should be ready, the image should be ready for you to access, so that if any trouble is found, then it could be managed well. For closure of the hemipelvectomy, there are two types of flap that could be done, the anterior flap or the posterior flap. We could see here that this is the incision done for the anterior flap, which is used to cover the posterior aspect of the hemipelvic, which has been incised. And then moving on to other types of amputations, which include the hip disarticulation. Hip disarticulation is a rather straightforward injury with a racket incision that is being made over the pelvic. We could see here the incision is situated slightly medial to the anterosuperior iliac spine. A racket incision is being made. Major vessels are being ligated, and the whole lower limb is being cut over at the hip joint, and then the flaps are closed from medial to lateral. Now moving on to the amputations on the lower limb, there are several types of above knee amputation, which includes the high, mid, femur, and supracondylar above knee amputations. Now each of these have its own description of what types of vessels should be looked for and should be ligated and dissected. Next, I'm going to present to you a little bit regarding the technique. You should always remember that the flaps could all be done in a standard anterior posterior fish mouth type, or it could also be a medial lateral flaps. Postoperatively, rigid post-op dressing is mandatory, as I've mentioned before, that it promotes the better healing of amputated stump. And next would be the knee. Some of you may have read about this, but some may not. And you should know that during surgery, sometimes the surgeon may place a catheter that is placed underneath the epidural layer, and these are usually done. This is the picture here. This epidural catheter provides access from the external area for an additional anesthesia. So epidural catheter can be flushed with bupivacaine and introduced into the epidural space. And then the neural sheath that has been opened up here is sutured back over the catheter with the absorbable structures, and layers of myodesis is being done to cover the end of the femur, and then the quadriceps and the hamstring muscles are myodesed to each other to cover the bony end of the femur, and the adductors are tenodesed to these muscles. Okay, next would be the below knee amputation. Usually the recommended length is around 12.5 to 17.5, although there are some formulas out there that could be used to further calculate how long the stump should be based on body heights. But this is the general number that you could use. And although several techniques are available, long posterior flap is preferable because of the increased vascularity of the area. The flaps are more likely to survive. The fibula is usually cut shorter than the tibia, and myodesis with drill holes and placement of epineural catheter can sometimes be done, and wound closure, and do not forget rigid dressing. That would be all for today's lessons. I hope you enjoy this video and may it bring you enlightenment on these topics. Thank you for watching. Please subscribe to my channel if you like to view more of these contents. Goodbye.